other conditions, two of the speakers have not been able to make it, so we are three speakers. Dr. Deshpande, who is our president, and Dr. Vinita Gupta, who is working as additional professor at AIIMS Rishikesh, and myself, I am secretary, Dr. P.K. Pandey. So we'll be having three talks. One will be broadly on amblyopia. The other talk will be by Dr. Vinita Gupta. She'll be talking upon on infantile esotropia, which is again a very challenging and very complicated condition. And lastly, I will be talking on CCDDs, which is again very diverse topic. So I think we'll have a lot of issues to discuss. So first talk will be by Dr. Pradeep Deshpande ji. He'll be talking on amblyopia.
Worthy Chairman, sir, dignitaries of the dais, my young friends, लगा क्या फोकस किया फोकस करो मैंने किया था उधर किया था नीचे आज सुबह किया था क्या
You can give it now, or maybe Dr. Vinita can start. हाँ आप कर लो तब तक आप यहीं दे दो. We will take it right now. कंप्यूटर में वहाँ पे दिया हुआ लेके नहीं आ रहा.
Good evening, everyone. So I'll be talking on one of the debatable topics in pediatric ophthalmology, which is infantile esotropia. So I'll be talking about the issues which are debatable in this. So whenever we see a baby like this, which I've shown in these photographs out here, so we need to see, do we need to intervene early? What is it, reliability of measurements in these children? Obviously, it is very, very difficult. And we have to be careful because obviously this is a period when the exposure to general anesthesia, a lot of studies which have said that larger the number of exposures, longer the time of exposures, all these are very, very harmful for the brain of the developing child. And also we have to look for the delayed overcorrections, especially if we are doing large amounts of surgery in these children. So again, that is another thing which is to be taken care of. And obviously, if you are doing delayed surgeries, the role of accommodation, which comes into play at around 2.5 years of age, that also has to be taken, especially if there is a high AC by A ratio. And the other coexisting abnormalities along with the esotropia in these children, there may be associated inferior oblique overactions, there may be DVDs, all those also have to be taken care of. So the total number of surgeries in these patients over the lifetime. So all this is a very, very complex issue. So that's why there are lots of things which are debatable in this. The first thing which I'll be talking about regarding this is the timing of intervention, whether we should be intervening early or late. So the school of thought from where all this process started, whether early intervention should be done or not, was can ophthalmologists, as an ophthalmologist, can we repair all those neurological developments which are delayed or which are not in a normal phase in patients with infantile esotropia? With early surgery, obviously, earlier, anything, if you are able to align the eyes, obviously the stereopsis and the binocularity development would be better. Even if you're able to bring it to the category of monofixation syndrome, that is within 8 to 10 prism diopters of residual esotropias, that is transferring a patient from a large angle esotropia to a small monofixation syndrome, that is what is a Marshall-Parks legacy, which says that obviously that would allow us to allow the child to develop some amount of binocularity. And what is more important out here is not exactly operating them very early, but operating them as early as within 60 days or within 2 months of the onset of esotropia. That is the most important. So whatever is required is to align them as early as possible after the onset of their esotropia. So that is what is required. Obviously, there are various studies which show the quality of stereopsis would be better in those cases. Also, there have been studies which have shown the effect of this early intervention on cortical motion VER, and they have shown that adequate binocular alignment done during the critical period, as I mentioned earlier, gives better outcomes on MVEP, especially so the trend on this seen on the these multifocal VEPs was that if you do early surgery within 10 months for these children, obviously the results are better. That is indirectly indicative that their binocularity can develop if you are operating them at that particular age. So as I mentioned, early surgery, the pros which are in favor of early surgery is a better binocularity. Multiple studies are there. LA study, Birch has done various studies, all of which have said that at around age 6, if we compare the children who have had early surgeries before the age of 1 year, or if we compare those who have late surgeries around 3 years or 2.5, 3 years of age, obviously the stereopsis, the basic stereopsis or the gross stereopsis is better in the group which has had early surgeries. Although the finer quality of stereopsis may not be as good for both the groups, but at least the absence of stereopsis or gross stereopsis would be present definitely in those who have had an early surgeries. Better binocularity, better binocular visual fields, better, and all this together would help in developing a better visual behavior of the child, which will help in acquiring all those motor skills also, which are closely linked to his visual behavior. And a better cosmetic appearance always along with that. So usually the trend is now to operate, all the proponents who are for early surgery is to operate them within the good framework of 6 to 12 months of age, preferably before 8 months of age. However, the cons which are for early surgery, as we know, this is very, very young child, exactly knowing whether it is actually an infantile misalignment or is just a misalignment which is a temporary thing, or which is only which may spontaneously resolve, or is it actually a true strabismus? That is sometimes may become difficult to differentiate. Some children have shown spontaneous resolution, especially with smaller angles. That was what was shown in the congenital esotropia observation study, and also in the some pedigroup studies, which show that deviation less than 30 diopters, around 20 diopters, or milder forms of deviation may show some spontaneous resolution, especially if the patient is examined very early in life at around 20 weeks of age. Again, other thing is about 49% of these children may have coexisting, I'm not talking about cases of essential infantile esotropia who do not have a systemic or a neurological abnormality, but if we overall take the prevalence of infantile esotropia, that about roughly around 40 to 50% of these children have associated systemic or neurological abnormalities. And these children usually may present at a variable age, may not present as early as possible, and these patients with CP may be diagnosed much later, and there the results of surgery are very variable, very unpredictable. So in these cases, the binocularity and all those things which you are looking for are all secondary. The other things, the other motor delays, the other neurological delays take a priority for the parents as well as for the medical development of the child per se. The pros for the proponents of late surgery group, they said obviously there is, as we know, younger the child, difficulty in strabismus measurements, so all the measurements, the effect of the refractive error, as it is said, we do not know what is the impact of the accommodation which is going to come up in the later years. The concerns regarding general anesthesia, which I've already discussed. Also doing difficulty in these, difficulty of doing the surgery per se in these eyes, which are very, very small eyes, what are assessing the force duction, doing force duction testing for these children. Again, assessment of these tests is also very difficult. So all these factors are in favor of those who are the proponents of late surgeries. And also the poor outcome predictions, and the fear which is there in the parents amongst the fear of overcorrection, undercorrection, multiple surgery, which is a fear in the surgeons as well. And also these proponents of late surgery, they say that does esotropia actually matter in terms of stereopsis? Because as said, in some of the studies, it has been seen that although the gross stereopsis would develop, but the fine stereopsis still, even when we are doing an early surgery as early as around 10 months of age, may not be to that extent as it would for a normal child. So does that performance of not having very good neurostereography, does it actually make a difference if we are operating them early? So these are the factors which are going in favor of those who are proposing a late surgeries. And also worldwide, if we look at these figures, most of the children do not report to us at the time when we actually can do the early surgeries. Especially in a country like ours, most of the children are coming to us very late. Because either they are not approaching us directly as ophthalmologists, they are going to the pediatrician who still in present day-to-day times are saying no, maybe when the child grows up, the eyes will straighten up, because sometimes they're confusing the pseudo-esotropias as esotropias, and which they're probably differing. So the children report to us very late when they've already crossed that age of early period of early surgery. So early surgery, obviously as an ophthalmologist, as a pediatric ophthalmologist, I am a proponent of early surgery, and I would say obviously it has a hopeful prediction. At least if I am able to give them even gross stereopsis, I would prefer and go ahead with the early surgeries. Late surgeries, from the parents' point of view, from the anesthesia point of view, they are easy to justify. But again, if we have to go for a consensus, I would take the opinion of the panelist and the chairperson later on when I finish my talk. Obviously, early surgery, if you are able to operate then somewhere before the age of 1 year, that would be better, at least to attain some gross stereopsis. And then the second controversy which is there in the field of infantile esotropias is whether to do surgery first, or whether in this early period do use Botox or the botulinum toxin. There have been studies which have shown botulinum toxin being used as a primary treatment, and stable satisfactory results have been obtained. Again, their degree of deviation is important in these cases. It reduces the total amount of deviations. For example, we are dealing with large deviation. By giving some amount of Botox, we are bringing it to an extent of 10 to 15 diopters of residual esotropias, which could help in achieving some binocularity. So obviously, using Botox as primary treatment is what is these proponents of Botox as a primary treatment which are proposing as. It allows for the development of binocularities and allows the procedure to be carried for smaller angles where we are not planning surgeries. And this is one of the meta-analysis which was done with Botox as a primary treatment, where there were 9 studies, and the group success rate found in this study was around, the 9 meta-analysis was 76%, and the mean change in deviation which was achieved with a single Botox injection, the mean injections were given about 1.4 injections, and the amount of deviation which could be corrected with this was around 30 prism diopters. The dose varied according to the body weight of the child, and effect was lasting for around 3 months. Although the complications are known with Botox, like consecutive exotropias and ptosis and vertical deviations can occur after Botox injections. Again, there's another study which shows an inverse association between dose and the success rate, and more effective when there is, they use this for cases which has a larger deviation, 30 to 35 prism diopters, and they showed success rate to be 51% if it was less than 30 prism diopters, and more than around 40% if it was more than 30 prism diopters. But there was a good gain in the binocular vision, both with which they tested using the baglonostrated glasses, as well as there was an improvement in gross stereopsis in the botulinum group, which was compared with that of the surgical group. Again, there's another study where Gorsolera, which has again shown, in this study they did not find any significant difference in the binocularity which was attained in the botulinum group versus the surgical treatment group. And the median age of treatment was earlier in the Botox group in their study. So the general protocol, how it is given is basically obviously using a sevoflurane mask. You need not give a full anesthesia, and no EMG is required. You just can give it either as a transconjunctival injection, or you can dissect the conjunctiva and directly inject into the belly of the muscle and into the tendon of the muscle. And what was is being propagated nowadays is 5 international use of botulinum toxin in each MR, and which is equivalent to 0.05 ml for all ages, using a 27 gauge needle which is 1 millimeter long, 1 ml syringe, and injection time taken is only 1 minute. So the duration of anesthesia is not very long for this, and it can be done under mask anesthesia, as I told you. But the other proponent which is not in favor of Botox, which is saying surgery is the only treatment for this, obviously says that we do not know about this anomaly, whether it is just a neural anomaly, why is the angle so variable in these cases, is the potential for binocular lesion predetermined, and what is the window of opportunity. So why waste the window of opportunity by using repeated Botox injections, because you will have to repeat them. So this group then proposes obviously alignment with Botox. We are not able to go beyond a particular amount of deviation. It does not give us a full correction or the acceptable correction in patients who have more than 40 diopters. So then restoring alignment by surgery is the best. Obviously, we'll have a prolonged period, a sustained period of good alignment, which will help in achieving a good binocularity. And obviously, incidence of undercorrection in these cases would be lesser. So let's examine the evidence for the surgical group. Obviously, it has been seen by Yagasaki et al., where the duration of good alignment was very long. So obviously, within 8 prism diopters, which is strongly correlated with better binocularity, better sensory outcomes, giving us more consistent results as opposed to botulinum toxin. Number of GAs would obviously not required, repeated GAs would not be required unless until he develops secondary inflammatory overactions or DVTs, then when they will require a second surgeries. And So, and the cost issues also would be cut down. Obviously, Botox, repeated procedures required, repeated cost of Botox, all those factors are not in favor of. Obviously, would help a person or who is in favor of or a proponent of surgical group. So those factors play in favor of him. But there are few studies being done which are now proposing a combined treatment. So consensus, I would say now is moving towards a combined treatment where there are 6 RCTs which are going on at present, where they're saying that increased success rate can be done when the 2 procedures are combined. So if it is less than 40 prism diopters of your ESO deviation is present, then you can just do your surgeries, biomedial resections. But if it is greater than 40 PDs, in single sitting, you can do a biomedial resections along with the injection of Botox toxin into the MR. So the consensus, surgery remains the primary treatment, Botox, use it as an adjunct. This is the latest RCTs which are now working on it, so which is pointing to that. The third debatable issue in infantile esotropia is unilateral versus bilateral surgeries. There's not much debate left on this now. Most of the people are now preferring to do, if there are small deviations which can be corrected with the biomedial recessions of 6 millimeters, the pediatric ophthalmologists are preferring to do a biomedial recessions. If you need to add on, for larger deviation, add on another muscle, then you can go for a bilateral surgery and touch an LR of one of the other eyes if you're not doing a combined procedure of Botox. So that is one. MR weakening otherwise suffices in most of the cases. Bilateral MR suffices. So is a useful strategy. So that is a consensus now. Now the next question is, which is debate to, is whether to touch the infio-obliques at the time of the primary sitting itself or the primary horizontal surgery or not. There have been studies which have shown that DVDs, infio-oblique overactions may, over a period of 5 to 6 years when we follow up this child, even when they are operated for only horizontal surgeries during their early infancy, around 72% of congenital esotropias develop these secondary overactions. And these are usually seen at an average of around 3 to 4 years of age. And incidence was positively related to the number of horizontal surgeries which the child has. And it has been seen that if infio-oblique was touched in one eye, the other eye subsequently may develop an infio-oblique overaction. While in milder cases, this may not happen. The horizontal surgery itself may be helpful in correcting the mild infio-oblique overaction. Hence, has been seen that recurrences may occur even if we have touched the infio-oblique in the primary setting in 20% of the cases. So when to operate infio-oblique, that is again a debatable issue. So first we have to assess whether there is a primary infio-oblique overaction or not. So it may not be very easy to determine it at a very young age, or when there is a large angle of esotropia, when it will look like a pseudo infio-oblique overaction, we may not be able to judge whether it is actually a primary infio-oblique overaction or not. So in these cases, what we can do is we can look for we should be ruling out that it is not secondary to a superior oblique palsy. So we should look for any torsional head postures, we should look for depression defects, and if we are able to capture their images on fundus camera in the OT or under mask anesthesias, then only we would say that it is okay, primary infio-oblique action, we can think of touching it. Otherwise, there's no point, unless until we are sure that there's a primary infio-oblique action. At the time of the primary surgery, you should not go ahead with that. And also DVD has to be taken care of, which would usually appears late, after 3 to 4 years of age. So, as I said, we should treat infio-oblique only when we are sure that there's an elevation in adduction is there is a significant V pattern. Infio-oblique action is more than the esotropia, which means esotropia is only 4 to 10 prism diopters. I'm just giving you an example. And it is only primary infio-oblique action which is obvious in the child. Then obviously you go ahead with the infio-oblique surgeries. Or if it is significant, as I said, more than 2 plus or 3, or we have objectively documented an X-cycloversion in these cases, then we can, go ahead with the primary infio-oblique surgery at the time of horizontal surgery as well. No modification otherwise is required when you are doing this in the intended horizontal surgery. You do your horizontal surgery amounts the same as you decided based upon his ESO deviations. And the surgery which is preferred in these cases, obviously recession, no myectomy is to be done because we cannot grade the myectomies. And if it is, as I said, if it is an extreme case of infio-oblique overaction, when you know it is a primary infio-oblique action of a large angle, then probably can think of even doing an intranasal transposition. The last talk in this is again not much of debate left on this, occlusion before surgery or after surgery. Most of these cases of infantile esotropias per se, when they present to us early, within the first 2 years of life, because they usually have cross fixation and they switch over fixation in the primary gaze, so they do not have amblyopia. So the question of giving them occlusion therapy before surgery usually does not arise. If amblyopia usually tends to develop later on in years once the accommodative element comes in. So if that element is there, when they're presenting to us late at the age of 2.5, 3 years, that time obviously if the refraction is showing us significant accommodative element, then we should think of in terms of amblyopia, and that time obviously you'll have to give amblyopia therapy, because at that time even your stereopsis is not going to be much affected even if you delay the surgery by another 6 months or 1 year before when you're treating them for occlusion therapy. So 2 hours of patching according to the age of the child at that time, especially in these cases when there is an accommodative component along with it. Thank you.
He has really explained everything in such a detail that is beyond books. All the literature she has covered all over the world, and she has presented very nicely in front of you. These are all theoretical things are there, practical things are also there, and she has told you about the early problem of early surgery. Let me tell you my own experience of last only 20 years. These infantile esotropia or any type of esotropia, in cases of all intraocular cases, it is an emergency. You have to operate that child as early as possible. Otherwise, the amblyopia will set in and it will be a problem afterwards. Another most important thing, everybody tells that she has also told that the child will not be a psychological problem, will stray, will not go to school. But that is the first thing that I have observed in my practice. Many parents, they come to me, sir, my child is not going to school because all the children, they are troubling him, they are creating so many comments on it. So, in my opinion, this is the first thing that you should remember. And try to operate with children as early as possible. When to operate? As early as possible during the critical period of visual development. She has already told you, after 6 to 8 months. That is the time when the child is fit for the anesthesia also, and see that everything is physical pictures and everything is there, and you start to operate that child. But before operating or on when taking, after taking the child on table, don't forget to do one thing. 2 things. One, call a retina person at that time. Let him see the entire fundus properly. He should not miss a case of retinoblastoma. I've seen people, they are operated squint and then they found that, oh, it was a retinoblastoma. That was the cause of squint. So, take care. See the fundus on the table. Number 2, call your optometrist and do the retinoscopy on table so that you can give proper correction to that child afterwards. It is not possible otherwise. So these 2 things don't forget before operating that child or completing that surgery. Then, yes, definitely early surgery, try to learn perfect surgery, and surgery is the only thing that gives you very nice binocular development of binocular reflexes and stereoscopic vision, and including all other multiple visual functions deficits also will be covered, including amblyopia, visual acuity. Botox, he has already elaborated beautifully about the Botox. I don't have much experience, but I can tell you it's a good option, but it's a temporary, I feel. If you know how to perform good surgery, go ahead for surgery. Okay, thank you very much, madam. Excellent.
Sir, one thing just a moment.
You want to ask any question?
You want to ask, let me say something in the background. I think what is most basic is to understand that infantile deviations are not like any other disease. We were born like lateral-eyed animals, with the 2 eyes placed laterally, and there is no binocularity. Now, binocularity is learnt like a language. So, if the 2 eyes, we have moved our eyes forward and became frontal eyes. That was the necessity because we climbed the trees. So, this was a new thing which came in. So, whatever binocularity we are having, it is like language we are learning. So, if there is an obstacle of whatever kind in that first 2 years of time, then this is going to create problems. So this is not like accommodative isotropia, because the wiring in the optical cortex has to take place. If that wiring doesn't take place, the child will not have binocularity. And in pre-oblique overreaction, latent nystagmus and DVT are the outcome of the failure of binocularity to develop. So this has to be, and about other thing is the fixation develops by about 6 weeks. The child which is born a neonate is neither ESO nor EXO. A good number are drifting and a good number are in EXO. So by 6 weeks or so they start having fixation, and from 2 months to about 8 months they will develop urgency. That means the eyes learn alignment at different distances. So this is the learning phase, and after this is going to get cemented by about, of course the binocular revision takes till about 8 years before lasting, final work goes on till the child is about 8 years old. So if anything happens in this period, things can go bad even at later stage. So one has to see it in that light. So don't treat it as something like accommodative isotropia or any other deviation, because if this is not looked into, this can give rise to loss of binocularity and of course amblyopia and obviously. About surgery, if it is a large deviation, you can operate by about 4 weeks. If there is a consistent large deviation, more than 40% diopters, because some of these can also rebase by 6 months. So those cases which are controversial, which are less than 40, don't operate them by at least 6 months. But those which are consistent by 4 months, more than 40, maybe they can be done earlier. So earlier surgery is good, but it has its own issues, so we're not going into that. It will need a very large, much larger discussion. I think there's no time. You had some questions, please. What?
Sir, as a cross fixation, both eyes are not abducting. So does patching helps in abduction and preventing the contracture of MR? So ideally, up to differing of surgery, we should ideally patch either eye so that the contracture does not occur. Is it valid, sir?
Yeah, it is very much valid. Other reason for alternate patching is that amblyopia will not take place. There are 3 alternators, but still there should be a possibility of amblyopia. So alternate patching does help in more than one way. So if you are waiting for surgery, alternate patching can be done in the meantime. And amblyopia part, usually they are not amblyopic because they are alternate fixators. So they are not amblyopic, but if there is AIOCMTC1, then they can go for amblyopia. Other thing is about the refractive error. If you have a child who is hypermetrope with about 2 diopters of hypermetropia, that should be corrected. Less than that you may leave. But another child who is not esotropic and has still about 5 diopters of hypermetropia, you may still leave in a neonate. So that is again one thing to be kept in mind, that a child with esotropia who has more than 2 diopters has to be corrected. Otherwise, till about 5 diopters of hypermetropia, you can just observe and later on correct in a neonate with the young child. Of course, later on this will change. Any other question? Anybody else?
One thing more. If ESO deviation is up to 40 diopters, we can do bilateral MR recession, and after that also bilateral MR recession.
If you can correct by 6 mm of bilateral MR is the maximum you can normally do, because beyond 7 usually overcorrections are happening. We will limit the.
There is a consecutive exotropia after 7, but 7 is safe. Other thing is there is dissociated horizontal deviation in some of these cases. So if you should also look at what is DHD if it is there, because if you have done a correction and patient child has DHD and DVD, then this DHD will manifest after the surgery and he will go into sort of consecutive exo. So it was actually a DHD which you missed, but it has gone into a consecutive exo. So it is important to undercorrect those cases so that you don't land up in these things. So proper evaluation and primary oblique overreaction and DVD can come later by about 2 years or so, even if you have corrected. So this is a fallout of failure of binocularity. So this will happen irrespective of correction to large extent. I think with that we go to the next talk because we just have half an hour left.
Just one point I would like to say, in all cases of uniocular esotropia, we have to differentiate between eccentric fixation and Strabismus fixation. Please do exclude those things and try to correct them properly.
Next talk will be by Dr. Deshpande. He will be talking about amblyopia. He has done a lot of work on amblyopia, and let's hear him speak on this topic of choice.
It is a combination of my own research of 50 years and my experience. So the amblyopia, the strategy to achieve quality and stable vision. And just see, we have to think and rethink beyond targeting 6/6. These are something different for you and something new for you. I am going to tell you what is the difference. Over 100 years, in spite of trying different treatment regimes, amblyopia remains confused, unsolved, having a prevalence of 3 to 8% all over the world. 1.2% persons live with compromised visual related quality of life and being labeled as visually unfit for their specific jobs. Well, it is said that the management of amblyopia should be started when the head is born but the body is yet to be delivered. Is it possible? Yes. You know, the naming ceremony starts on 12th day onward. 12th day means Barso. On that day, this is a naming ceremony. On that day, if you keep 2 dolls over the cradle of the child, that will definitely help to develop the binocular reflexes also. And not only entertainment, but it will definitely try to help. The 2 amber colored dolls you can keep over the cradle of the child. Okay? These we call it as a Sandva or mother doll. Number 2, in all cases, whether it's a case of in all unilateral things, maybe cataract, maybe ptosis, or this is esotropia. Any unilateral things, they are not good. It should be always bilateral. So, if there is a central congenital cataract, maybe unilateral or bilateral, you can just do one thing. Put a drop of homatropine or cyclopentolate. In alternate day, even 1 drop is enough. Or in immature cases, children, you can dilute that particular drop and you can put it. But keep the pupil dilated and keep a flickering light over the cradle of the child till you perform the surgery of the cataract. So you have to utilize every day of critical period of life, that particular child, till you perform the surgery. Till you get a fitness of the child, physical fitness, anesthesia fitness, everything, or economic fitness. Till then you continue this regime if it is a central cataract. Dilate the pupil and it will definitely help to minimize the dense amblyopia, formation of dense amblyopia. And in same thing you can do in cases of ptosis. If it's a unilateral ptosis, if it's a bilateral, the child will look like this and you will try. There won't be any amblyopia. But in a unilateral case, you can put a small Tixo tape. You can see that. Put and keep the cornea moist and put a Tixo tape and put a flickering light over the child at least for 2-3 hours till that child sleeps. This will prevent. And after the age of 2 years, the child can be even, you can use a screen time, give him tab. This particular tab has a different types of exercises for the children and they can perform only after 2 years, only for 30 minutes at a time, not before 2 years, and can be repeated 3 to 6 times as per the severity of the amblyopia. The brightness should not be more than 60%. And in my tab, where it is a patented tab for the assessment and improvement of vision, if there is a auto shutdown mechanism which I have kept, after 30 minutes it will automatically shut down. So there won't be any problem for the child. Well, then another important point is that diagnosis at the earliest age is the problem with everybody. In all cases of strabismus or whether it's a esotropia, exotropia, in all cases I have told you, just now, that you have to see the fundus in detail to rule out the possibility of retinoblastoma and perform the refraction on the table. Yes, there are certain useful tricks for pre-verbal babies. You can just ask your computer person to prepare a cat4 and allure drum, which I have shown you here. In these cases, just rotate those strips gradually and take that child towards those strips. You can find the optokinetic nystagmus, or you will find the difference in his face. That particular child will show you whether he is having some vision or not from his facial expressions also. At home also, that child is looking at a doll upstairs at the top of the roof of that room, and with a the measuring tape, you can measure how much is the distance from that eyes of that baby, and that is the vision of that child. These are the simple tricks. And especially to overcome the hospital phobia, usually the children from 2 to 3 years of age group, when they come to a doctor's office, they start immediately crying or, oh, I want to go back. And as soon as you show them something interesting, A for apple, E for elephant, like this, the child will immediately tell you, oh, doctor, I can tell you that is a, and you can continue. This is the best time to screen amblyopic babies, when they start learning A for apple and E for elephant. Now, these are the days of artificial intelligence. Now a blink vision scanner is also available for babies to find out the amblyopia problem. And another important thing is that why amblyopia disorder remain unsolved. The issue of compliance to patching regime resulting into unpredictable improvement and regression of visual acuity. Penalization medicines have limitations. Binocular active treatments are good options, but the problem of improvement of other visual function deficiencies is yet to be solved, which is the main cause of regression. Why the regression occurs? That I am going to tell you today. Are under trial, they are unaffordable and institutional based. Continuous changing concept needs rethinking and thinking. Again, there is a change in the definition of amblyopia. Amblyopia has been defined as a unilateral or sometimes bilateral reduction in best corrected visual acuity without a visible organic cause. But as per the recent advances, amblyopia is a binocular dysfunction. In fact, the major mechanism is not only the lazy state of the one eye, but the active inhibition of the amblyopic eye by the dominant eye, which disrupts the equilibrium between the excitatory and inhibitory signals. When you start patching the one eye, the other eye, the patched eye will not allow that other eye to develop. It is just like human tendency. Okay, they will not allow anybody to go ahead. Okay, the same thing happens here also. In anisometropia, even if the non-amblyopic eye has almost 6/6 vision, both the eyes have few more visual function deficits. As per current management of amblyopia favors binocular treatment for faster and fourfold improvement of visual acuity. Meridional amblyopia is sort of anisometropia. As there is a high difference between two meridians, one meridian remains chronically blurred. One of the most common and difficult variety of amblyopia to treat glasses correction alone or even with patching. This is one of my paper to treat chronically blurred meridian. Then again passive versus active therapy, where the eyes and the person both are actively involved. That's why everybody is coming forward with binocular management and active management. There are so many people that are working on binocular management. You can use even a electronic spectacle envelope for the envelopes for alternate patching without any cosmetic problem. You can use a tab. And now the most important thing that I'm going to tell you something different today. Why there is need of thinking and rethinking beyond targeting 6/6. Everybody is trying to increase that visual acuity up to 6/6. But both the eyes might have multiple visual function deficits apart from the deficit of visual acuity. Amblyopia is a disorder, is a syndrome or a plethora of so many deficiencies like crowding phenomena, reduced recognition of contrast objects, depth perception, positional uncertainty, and so many things. All the things, and just remember, if the contrast sensitivity or the stereo acuity does not improve along with visual acuity, the vision is going to, there will be a definite regression. So remember, all the things, there is a complementary faster route to achieve high level and stable vision. Playing specific video games enhances the improvement of recognition of contrast object and stereo vision. I think this is totally new for you. There are so many people, they have already started working, and I have worked already. My games will be available within a week's time. These are the simple games for contrast sensitivity. This circle will go on in moving, and the child has to tap a particular color, and these are the same color with different percentage, 100%, 60%, 30%. And why this is a, it's an interesting game also for the child to play, and this will definitely help to improve the contrast sensitivity. Color contrast. Okay, these are all patented from my visual acuity assessment and improvement thing. So for stable vision, you have to try to improve the other visual function deficits also, then the acuity will automatically improve and it will be a stable and good quality, high level vision. So this is one of my book on amblyopia. You will find these all tricks and tips in that book, and these are the different games, and my tab, which is a patented tab, that also inaugurated by the President of American Academy. Thank you for giving much time, sufficient time. Thank you, Chairman Sir. Thank you, audience. If you have any questions, you can go ahead. No problem.
Anyone? Because we're running short of time, so amblyopia is a very huge topic, and as you know, a lot of things are happening, like optics, and but occlusion does remain one of the most important pillars of therapy in today for almost 150 years since it was started. So it needs much wider discussion. So I think if there is no question, then we move to the last talk of this session, and I'll be talking about CCDDs. Now, what are CCDDs? Congenital cranial disc innervation disorders. Now, the name by itself suggests that these are congenital, these are cranial, and there is a disc innervation, and it is a disorder. Now, this term was coined by in 2002. It's 20 years now, and this term has stuck, and lot of conditions have been added, lot of things have been learned through genetics and through imaging. So those two aspects have really added to the wealth of information, and new entities have come in like third nerve palsy, fourth nerve palsy, and so on. So we'll be just trying to, we'll just talk about those conditions in a brief way because time is very limited. Now, what are CCDDs? These are abnormal development of cranial nerve nuclei and or their axonal connections. That means either the nucleus or the peripheral nerve is not developing properly. Some of these also have maldevelopment, which is prenuclear or supranuclear. So that you should also keep in mind that you can have conditions like AGPPS, where the problem is in the midbrain and pons development. So that can also happen along with this. So these could have broader implications for neurological development. These are mostly heritable, but can also be sporadic because of mutations. So there is, first thing is there is a primary disinnervation. That means there is lack of innervation. Either the nucleus has not formed or it is hypoplastic, or the nerve has not formed or it is hypoplastic. So that is the basic substrate on which it is going to develop further. So secondary thing is that is disinnervation. That means something else comes and supplies that part of the muscle. Like if you look at the embryology, the third nerve is going to supply the entire mesoderm around the globe, which is going to form the extraocular muscles. The sixth and fourth nerves are later invaders. They come later and claim their territory. Now, if there is some problem in this division of their territories, then there will be a problem. So, all this thing is very well guided at biochemical level. So, it is very complex matter and very well guided and done by the body. Now, if there is any failure anywhere, there is going to be a problem. So, the hallmark feature is that there is a variable component of paresis and restriction. So, this becomes a complex strabismus because you have a paresis and you also have a restriction. Now, this component may change. You may have conditions which are mostly restrictive and you may have conditions which are mostly paretic. So, you will have wide spectrum of presentation from almost total restriction to some paresis, and along with this also comes some kind of aberrant innervation. Restriction, paresis, and something coming elsewhere. So, it makes it very complex. Like you all know about Duane's retraction syndrome. At times it can be mind-boggling and you wonder what you are dealing with, but then you know that ultimately it is DRS. So, broadly we can have them at two levels, either at the level of the midbrain and the level of the pons, because that is the basic brain, the medulla, the pons and the midbrain. Rest of the brain has come up later. It is like an add-on. It's like a sweet dish which we are having. Most lower animals don't have this kind of cerebral cortex. Six-layered cortex is a luxury. Most non-mammals and lower animals will have maximum three-layered cortex. So, nature gave us 6 layers and making it all the more complex for all of us. So, at the level of the midbrain, we have what we call as congenital fibrosis of extraocular muscles, which is again a very important condition, rare, but once you see it, you know that this can be quite mind-boggling. Then you have congenital MED, which is monocular elevation deficiency. You have congenital Browns, which is a late visitor to this group because we knew about Brown since 1950 when it was described by Harold Ridley Browns, but a lot of water has flowed since then. Then you have a small group of congenital third and fourth cranial nerve palsies. You, I think, already know that the third nerve palsies, which are congenital, can also have aberrant innervation. But we never looked at them at CCDDs, but now we know that a good number of these on neuroimaging also, they show a lot of other evidence which shows that these are CCDDs. And fourth nerve palsy, you know, is the commonest congenital cranial nerve palsy as far as we are concerned as ophthalmologists. And there is very often hypoplasia of the fourth nerve nucleus and the nerve and the muscle also. A good number of about 50% of superior oblique palsy will have superior oblique hypoplasia. So, there is a direct relationship between the nerve and the muscle. If there is a problem with the nerve, muscle is going to be affected. And then of course, congenital ptosis, you all know, especially if it is bilateral. Then at the level of pons, you have Marcus gun, jaw winking phenomena. You have DRS, which is the commonest CCDD, as you all know. You have synergistic divergence, which could be with DRS. And then you have BSAS and ABDS. Now, what are these BSAS and ABDS? Bosley-Salih-Eloreni syndrome, which is seen in Gulf countries. And this is like bilateral DRS with a lot of middle ear problems. And then you have ABDS, a substance brainstem dysgenesis syndrome. This is seen in South America. So, both these conditions are SAL4 mutations, SAL1 mutations, which can be shared with DRS. So, there is sort of a cross connect with DRS, synergistic divergence, BSAS and ABDS. Then you have SGPPS. What is this? Horizontal gaze palsy with progressive scoliosis. There is a scoliosis which may not be apparent in a child which is young. By 2 to 3 years or by 7, 8 years it will come. It is autosomal recessive, so a good number will not be affected, or parents may not be affected, but children may be affected. And you will have eyes which look perfect. In fact, many of these cases get missed because I know of cases which have gone to All India Institute, have not been diagnosed, gone to orthopedics for scoliosis, and they have not been diagnosed. So it can happen. All of us can make mistakes. So you have HGPPS, we'll show you some cases. Then you have Mobius and Kalman. I am sure you must have heard about this. Mobius was not an ophthalmologist, he was a neurologist at Leipzig who classified these all cranial nerve pulses into different groups. And he placed some of these 6th and 7th nerve pulses together, which now we call as Mobius syndrome. Then you also have congenital facial nerve palsies and crocodile tears. Crocodile tears you all know, I suppose. Crocodiles are supposed to cry when they eat their prey. It is a myth. Nobody knows they actually cry. So crocodile tears come from that myth that when you are salivating, you are also having tears. So this is kind of disinnervation. Now, tubulins are important. These tubulin proteins are very important for neuronal development. Now, if there is a problem with these tubulin proteins, then you can get into a lot of problems with the CNS development. So, two types of CFUM, which is TUB3 and TUB2B, they can give rise to a lot of CNS involvement also with these CCDDs. So, you may have CCDDs, you may have CNS involvement without CCDDs because of this TUB2 and TUB3, or you can also have CCDD with a lot of CNS involvement. So it needs to be looked beyond eyes. You also have to examine them systemically and see what else they could be having. As I was talking, with TUB3 and TUB2B, you can have malformations of the cortical development, dysgenesis of the corpus callosum, corticospinal tracts, basal ganglia, and hyperplasia of the oculomotor nerves, microcephaly, microgyria, polymicrogyria, vocal cord paralysis. So all these things can happen, and of course they can have intellectual disability. So you need to have a broader and global evaluation in these cases. Now imaging has done a very good, has been a great help. Like we know 1/3 of the third nerve palsies may show hypoplasia. About up to 70% of fourth nerve palsies can show CN4 hypoplasia or aplasia. And in DRS, and you have cranial nerve 6 absence or hypoplasia in type 1, it could be absent. In type 2, it is present, and in type 3, it could be variably present. So in DRS also, imaging is going to help you. Mobius syndrome, as we were talking, 6th and 7th nerve, you can have CN6 and 7 aplasia or hypoplasia, and it has a lot of systemic involvement. Mobius, we don't have time to talk about this in detail. CFM3 shows cranial nerve 3rd, hypoplasia, and synaptic divergence and synaptic convergence can mostly show CN6 hypoplasia because they are happening at the level of the pons. So we talk about CFMs. These are, as I said, these are primarily fibrotic situations, restrictive strabismus, because there has been no innovation, so they have gone in for restriction. So the main thing is that there is paresis followed by restriction, but paresis remains the primary event. Now there are at least 8 genetically identified syndromes which we already know. Tuchel syndrome has not been identified, so more will be added to it as more and more genetics progresses, so probably we'll add more to it. Now inheritance is autosomal dominant for most and autosomal recessive for CFM2 and Tuchel syndrome, which we don't know till now. Rest are autosomal dominant. Now phenotypes can be very broad. There are a lot of variability in presentation, so they cannot be a typical presentation because depending upon the restriction, depending upon the horizontal movements and the strabismus, lot of variability can be there. But what is most consistent is that there is by and large ptosis, which is also not always there. You can also have a lid retraction, but they have a down gaze, eyes are fixed in down gaze, and there could be an A pattern, convergence in up gaze and divergence in down gaze, what we call as A pattern. So you have ptosis, you have eyes fixed in down gaze, Bell's is poor, and they will usually have a family history. Chin up position because eyes are fixed in down. I think we can extend by 5-10 minutes.
Yes, sir.
Okay, thank you. So this is one family. You can see 3 generations, the grandfather, the mother, and 2 children. They all have similar mirror image picture. All of them have CFM1, eyes are fixed in down gaze, all of them, and they are not able to elevate the eyes. If you look at this girl, there is an exo also, there is a variable limitation of horizontal movement, there is ptosis, trying to look up, there is lid retraction. They have a lot of astigmatism. Important to keep in mind that they can have refractive errors and large amount of astigmatism. So you should always refract them, do their refraction, and they will have amblyopia, very poor binocularity because they have never had an opportunity to fuse. So amblyopia and binocularity will be very important to look into. This is showing you have an extortion in this child, fundus extortion, as you can see. Another girl in this group only has intorsion. So why one has extortion, other has intortion, two sisters. Will not be able to go into this at this moment. This is showing CFM2. You can see the eyes are nailed to the lateral canthi. Both eyes, because the lateral rectus is the only muscle which is left. The third and fourth are both affected. So CFM can affect third primarily and also fourth. So here you have that eyes are almost fixed in the at the lateral canthi, and this is mostly seen in Middle East countries with a lot of consanguinity. We don't see it very often here, but just to show. This is showing us atypical presentation. You have a CFM3 which can have lot of variability in presentation. Here you have this 25-year-old boy. It's a rare phenotype. You have, there is a congenital MED in the left eye. There is a typical coloboma. He has high myopia. And there is an ophthalmos and this thing, cystic eyeball in the right eye. So it's and he also had cryptorchidism and typical high myopia with IR fibrosis. So he also had systemic involvement. So don't forget to look at them systemically, otherwise you will miss a lot of kidney issues, and these things can happen, cardiac issues. This is showing you, very often have seen MED with MGP. So all these MED which have IR restriction and MGP, are a good number of these are CFM3 because of TUB2B and TUB3 which are presenting like this. So MED also need to be looked at as a fragmented entity. Some of these are not, MED is just a finding that eye is not able to elevate. It is not a diagnosis. The problem is that we tend to make it into a diagnosis which is not true. So this is just that some of these could also be CCDDs. This is showing one eye Brown's and other eye superior oblique palsy. Very interesting presentation, and is also sort of albinism in this child. So you can see that the right eye is Brown's, it is not elevating at all in adduction, and the other eye is over elevating in adduction. So this can create, these are reported because both are CCDDs, so you can have superior oblique in one eye and Brown's on the other eye. This is possible, so always look out for these if you have a case like that. This is just to explain why we get into superior oblique palsy and Brown's, the same process, continuous process. We will not go into that detail. This is showing superior oblique palsy. You all know the tendons are tenuous and they could be quite or even absent tendons, and very typical presentation if it be. These are few third nerve palsies I will be showing you in brief. This was like right third nerve palsy, atypical presentations with lot of findings which are beyond third nerve. So you can see right exo, and the eye is hypo and pupil was spared, and there is not much ptosis. There is slight left-right head tilt. If you look at the motility, the right eye, which is largely exo, which is going beyond, it is adducting. In up gaze, there is actually adduction. From exo, it has gone into large ESO, and down gaze, it goes into a large exo. So it is an A pattern, which normally you don't see like this. An eye which was in exo is going into extreme ESO. So this can only happen with aberrant innervation. And there is also synergistic divergence in this child as he is looking to this side. If you can pointer hai there is time. When he is looking to the left side, you can see the eyes are diverging and this eye is going up also. So there is a vertical divergence and also synergistic divergence. A very interesting presentation. And if you look at this, if this plays, he will show you nystagmus. See, you can see a nystagmus, which is jerk nystagmus to the right in this eye, which is normal eye otherwise. And now when you look to the other side, this eye goes into synergistic divergence and also goes up. So there is a vertical and horizontal synergistic divergence. And this eye lid droops and other eye is elevating. So a lot of disinnervation. Okay. This is showing intorsion in this thing, sort of intorsion in right eye and extorsion in left eye. Now where do we see this? This is a conjugate torsion which you see in ocular tilt reactions. One eye intorted, other eye extorted. Otherwise it doesn't happen in most of us. So this is again a very abnormal finding, and I'll show you something more interesting. As this child looks up, you can see that the intorsion which was there in this right eye has gone into extorsion, and other eye has got into intorsion. So this change in torsion has happened because of gaze. So this is something very, this case has been present, I mean, this is published case. So very interesting. This shows that there is involvement of the autolytic pathways which are used in vestibular ocular reflex. So this is a complex thing from the vestibule, the saccule, utricle, and the semicircular canals. These along the vestibular nerve, they are crossing over going to the vestibular nuclei. From there, they are crossing at the level of the sixth nerve and ascending in the MLA from the opposite side. So if there is an affliction along with this pathway, you can have that kind of conjugate torsion which you are seeing here. So beyond third nerve, there was involvement of these pathways as well in this patient. That's what I want to stress. This is another child, again third nerve palsy. It will pass on, no ptosis and little AHP. This picture is getting cut off a bit anyway. This is showing a video. You see this is oculomotor and trigeminal synkinesis. Now he opens his mouth and eye moves in. And see, the eye is moving sideways. In Marcus gun, what you see is that the lid is opening. Here what is happening, and see, again you have synergistic divergence here. The eye shoots down and diverges. So similar picture as compared to that. But here instead of synkinesis with the upper lid, the medial rectus and lateral rectus are synkinetic with these pterygoid muscles. So this is again rare presentation, has been published. This is another child, again third nerve palsy, and you see here is something very different a bit. She has people involving third nerve, and she will just press over upper lid and this will open. Now this will remain open for some time, about a minute, and again there will be massive lacrimation and this lid would suddenly drop. There is no improvement in the ocular motility, only the lid elevation. Now this is dropping, and again she will do this. So what is happening here? The molars muscle acts as like a muscle spindle for the LPS. So what probably she is doing is that she is stimulating her molars through proprioception, and she is getting this lid elevation. So important to keep in mind that molars has a very important role, and if they is aberrantly innervated, these kind of things can happen. AGPPS very brief, as some cases you will miss them if you're not careful. So the three components: horizontal gaze palsy, the scoliosis, and X-ray findings, MRI findings, which show pontine hypoplasia, split pons, butterfly medulla, and absent facial colliculi. These are all features of brainstem hypoplasia. Of course, scoliosis and this part I am not going in detail because we are short of time. This is showing 11-year-old girl, you can see, and she is, other than scoliosis, she is scoliosis to the right, and look at the movements. No horizontal movement. Vertical movements are perfect. They have convergence which is intact, and they may be confused with bilateral DRS. If you don't look at them carefully, somebody would think that this is DRS, but this is not DRS because there is no globe retraction, no other finding of DRS. Showing pupils is anisocoria and iris hypoplasia, which you can see, but these are very subtle. If you notice, Another girl with accommodative esotropia, AGPPS. She was hypermetrop of 5, but they don't respond to treatment because the eyes cannot move in vergence. So this hypermetropic accommodative hypertropia cannot be corrected by glasses. So we had to do surgery, and this is the after convergence you can see is intact in this girl. This is third one with exotropia, another girl with AGPPS and exotropia. You can see large exo and V pattern, and again intorsion in this. We will not go into this detail. This is a gentleman, as we're talking about Paul Julius Mobius, a Leipzig neurologist, also known for Mobius sign and Mobius disease, and wrote interesting monographs on physiologic weak-mindedness of women and pathology of men of genius, which were interesting monographs at this time. We will not go into the detail of Mobius syndrome. You can see here the left side Mobius with exposure and facial palsy of the left side, He is not able to close that eye. If you look on the left side image, there is good base phenomena, but total inability to close the upper part of the face is involved more. The lower part, this mouth muscles may still be spared. So that's another feature. And usually bilateral, cases can be unilateral. You may have an ESO, you may have an EXO. Facial palsy may not be very gross, and if you are not careful, you will miss it. This is showing hypoplastic tongue by Fisher, hypoplastic tongue, which may also have hypoglossal hypoplasia. The tongue could be diverting to one side because of hypoglossal nerve palsy. And here you have facial nerve palsy, which is showing that there is inability to close the eyes. This is showing arachnodactyly and clinodactyly in these cases. They can have a lot of orthopedic issues, which was known as Hanhart syndrome. So orthopedics people look at it differently as we look as differently. Duane's is another most important CCDD. You all know, you have all seen Duane's syndromes, and there is no point talking about it. More we talk, more we get into difficulties. So a very diverse presentation and very challenging. And genetics is either it is autosomal dominant. If you see a bilateral DRS, you should always think of, you should always try to do the genetic study on these children, because very often the bilateral DRS could be inherited. So you may have autosomal dominant or AR. Most simplex cases are sporadic, and the genes which are important, CHN1, SAL4, and HOXA1, which is shared by BSAS and ABDS, as I was saying sometime earlier. So this part needs to be done. I will not go into this presentation in detail, you all know. And to conclude, the concept of CCDDs is in a phase of evolution. Recent advances in imaging and genetics have advanced our understanding of CCDDs, and more have been added. Some congenital third and fourth nerve palsies, MEDs, Browns need to be classed as CCDDs because they share those features, and surgical interventions are challenging. Results modest, and multiple procedures may be required. So before doing surgery, you should be careful which ones to touch, which ones to refer, which ones not to touch, because if you touch every case, you will burn your fingers. So be careful in diagnosing, image them, do genetics if possible, and assess them, do their FPT, and only after that you should have a clear indication to do a surgical intervention. Treat amblyopia, treat refractive errors. Very important to keep in mind. Thank you so much. Any questions anybody has, we can address.
Thank you, Dr. Pandey, sir. He has elaborated the entire most complicated topic, most complicated. Even I could not understand so many things. But he has simplified and shown beautiful videos. That's why we could understand at least 50% of it. Let us hope. And let me tell you one thing. Today I have seen is that he is academically very perfect. He's just like a very super teacher. But as a SPOCI secretary, he is doing excellent job. He is arranging all the conferences very nicely, arranging all the lectures. Everything is doing it very efficiently. So hats off to him. Give him big hands.
Thank you, Dr. Pandey. All with your support and cooperation and help that we are, whatever little we are trying, we are able to do. And thank you all of you for having come and attended, and I hope you learned something. And if there is anything you want to ask, we are here to clarify. We request you to become members of this POCI and participate in our conferences. It is a collective responsibility and effort by all of us, and we need to promote this specialty, because I think a lot of things have been happening which should not be happening, like amblyopia, like strabismus not being treated, and they are being going to adulthood and then ending up as almost one-eyed. So a lot of psychological issues, a lot of financial issues, and it's a very situation which is quite complicated and needs to be looked into. Thank you so much. There is no questions. We close this session here. Thank you. You should have been here. You're busy with your laptop. Please come, all of you. We'll have a group photo. Please. सभी लोग आ जाओ. You are very few anyway. And Dr. Krishna is joining us at the end of the session. Thank you so much for coming. Please come, all of you.